So good evening. Sorry, ma'am.
No, nothing. I should have stopped.
No, yes, ma'am.
Yeah.
Ma'am, should I stop your screen share from my end?
Just for the moment until we get to the introduction.
Yeah.
Okay, I have stopped it from. Okay, ma'am. So good evening and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a station assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event organized by Society of Anaesthesia and Perioperative Care. And the topic of today's session is anesthesia for retroperitoneal sarcoma resection and LND. Key insights. So let's begin today's session, for which I would like to hand over the session to Dr. Anjali ma'am. Over to you, ma'am. Please proceed with your talk.
Thank you, Rupsa. Welcome, everyone. Thank you for joining us. I know it's been a busy week. Hope you had a lovely Sankrant, Pongal, and so on and so forth. So this evening, we are going to talk about retroperitoneal sarcomas and retroperitoneal lymph node dissections. Dr. Aishwarya Ramkrishnan is our speaker. Aishwarya, can you share your slides?
Yeah.
Aishwarya is my colleague at PD Hinduja Hospital and Medical Research Center in Mahim, Mumbai. In addition to being a very competent and dynamic anesthetist, she also has an MBA in Health Services Management. She's worked in onco anesthesia primarily in Chennai for the past 8 years and also at TMH for some time. Her main interests are thoracic anesthesia, difficult airway, acute pain services, and she's also interested in quality improvement. So this is our 65th session. Let us go ahead and see what Aishwarya has to say about all of this. Over to you.
Yeah. Good evening, everyone. It gives me, and this opportunity, I am very humble to receive this opportunity to present this topic. And I thank the organizers for this, and I thank the moderator, Dr. Anjali, ma'am, for giving me this opportunity to present today. So moving on to the topic per se, today is about anesthesia for retroperitoneal sarcoma lymph node dissections. Coming to the basic anatomy of the retroperitoneum, a retroperitoneum is the complex anatomical space that is located behind the peritoneal cavity. It is bounded superiorly by the 12th rib and inferiorly by extends up to the sacrum, and anteriorly by the peritoneum, and posteriorly by the abdominal wall, and laterally by the quadratus lumborum muscle. And as we can see in this image, this retroperitoneum has very crucial structures that involve both the kidneys, the major aortic, and the IVC, and it is studded with lymph nodes, and it has all the sympathetic plexus. So this makes it an important anatomical structure, and the tumors of this retroperitoneal region can have a tissue of origin of mainly these fat, connective tissue, and muscle tissue. So the neoplasms that involve the retroperitoneum are the liposarcomas, lipomas, leiomyosarcomas, and gliomas that may form the major pathology that involves the retroperitoneal tumors. So what are the incidence of these tumors is that they are very rare in population. It is about 0.3 to 0.4% per 10,000 of population. So, and among the sarcomas that occur in the body, the most commonest location is the retroperitoneum. And the peak incidence is around in the 5th decade of the age. So how do these patients present to us? The presentation is quite late because the retroperitoneal space per se is very large and that can accommodate a huge tumor. So the patients present with vague symptoms like abdominal pain, non-tender mass, pain during stretching, and increasing abdominal girth. Sometimes they even present with the lower limb edema because of the compression of the vessels and DVT, which leads on to further evaluation and found to have a retroperitoneal tumor. So, what is the oncological management of these retroperitoneal tumors involved? The surgery is the mainstay of treatment. These sarcomas, as we all know, are very less sensitive to chemoradiation. So, surgery forms the mainstay. And it has been found that 75% of the resections of these retroperitoneal tumors involve concomitant resection of any adjoining intra-abdominal visceral organ, especially the kidney and the small bowel. And these tumors are usually resected en bloc. There is no piecemeal resection, because en bloc resection is mandatory to achieve an R0 resection. And these en bloc resections are usually if associated with in vessels, are also excised en bloc. So, in spite of such an aggressive tumor removal, the local recurrence rates are almost like 50% over 5 years. And only when there is a vascular involvement that precludes the resection of proximal superior mesenteric vessel or the bilateral renal vessel, all other organ involvement are usually removed with en bloc resection in these tumors. So coming on to the major anesthetic part of retroperitoneal tumor, the challenges we face in these tumors is that we will be dealing in the session also will be the preoperative optimization and evaluation. This being a major surgery, huge abdominal mass, prolonged duration, and the hypothermia associated with it, the massive blood loss and the organ dissection that happens in these tumor, massive fluid shifts, and the anticoagulation management and the post-op care. So preoperative evaluation starts with our routine investigation and evaluation of anemia and preoperative renal function along with the nuclear renogram to know the split kidney function. As I said, the nephrectomy is the most commonly associated tumor associated with these tumor resection. We need to know the function of the individual kidneys. So renogram plays an important role in that. The preoperative nutrition and anemia correction is mandatory. We have to look for the frailty and albumin levels in these patients and associated cardiovascular evaluation, especially if the patient has received a preoperative cisplatin that can cause a QT prolongation in the ECG, and any chronic DVT or a pulmonary embolism that has occurred, and we need to know the biventricular function in these patients. So echo becomes a mandatory in these patients. So prehabilitation involves intensive spiron strengthening exercises that can be done if we have which will be time limited. The respiratory evaluation involves the X-ray chest and the CT chest, and also the pulmonary function test. So why is respiratory evaluation important in these patients? Because most of the retroperitoneal resections and the lymph node dissection patients are mostly post-chemo. If they have, and if it is done for a germ cell tumor, they would have received a bleomycin, and this may cause a bleomycin-induced lung injury. So to know more about the bleomycin-induced lung injury, we need to know the effect of bleomycin. So how the bleomycin have an antineoplastic effect is it chelates with the oxygen and the ferrous ion and causes cleavage of the DNA C3 and C4 bond. This is how the antineoplastic effect of bleomycin works. But what happens in other tissue is the bleomycin hydroxylase enzyme breaks down this bleomycin and doesn't allow it to cause any normal tissue DNAs to break. But in lung tissue alone, thus bleomycin hydroxylase is lacking. That leads to this organ-specific lung toxicity in patients who have received bleomycin. So other mechanism involve increased neutralizing pro-inflammatory cytokines, increased activity of myofibroblasts in these cells that leads to new collagen deposition leading on to fibrosis. So what are the risk factors for anyone to develop a bleomycin-induced toxicity is age at which they received these chemo, a more cumulative dose, that is more than 400 international units, impaired renal function, patients who have received bleomycin along with cisplatin or gemcitabine, who have associated cigarette smoking, and patients who have received filgrastim during their chemo. These patients are at high risk of developing bleomycin. So how this toxicity? So how do we recognize this bleomycin-induced toxicity? Is the most sensitive indicator is the DLCO. The DLCO, as we can see in this image, as the patient receives some BP chemotherapy, the DLCO drops drastically. And even though over years it comes back to normal, but this reduction in 50% from the baseline PFT or the pre-chemo PFT is an indicator of subclinical lung injury. And if this DLCO falls by more than 40 to 60% from the baseline, that indicates a definitive toxicity. So, and other PFT values that happens in with bleomycin-induced lung injuries, it demonstrates a restrictive lung pattern with decreases in the forced vital capacity, total lung capacity, and functional residual capacity is also decreased. So other respiratory evaluation to know about the bleomycin-induced toxicity is the imaging studies, X-ray and the CT. In X-ray, we can look for the new parenchymal opacities, and even in the PET scan, there may be increased bilateral uptake. And we have to look for the interstitial pneumonitis that happens in the acute lung toxicity that is predominantly affects the upper lobe, and there may be bilateral ground glassing opacities, and eosinophilia may be seen in the total blood count. So this usually presents like an acute eosinophilic pneumonitis. The main treatment for an acute bleomycin toxicity will be pulse steroids. In long chronic lung injury or fibrosis, there is no role for steroids. So coming on to the preoperative imaging and planning for the surgery, the CT scan and MRI plays the major role. With CT scan and MRI, along with angiography, we can know the tumor size, we can know the proximity to the vascular structure, we can know about the other solid organ involvement. We need to discuss with the surgeon the extent of the surgical resection, and also know the involvement of any vertebral body that is the forms the posterior border of the peritoneum. So the retroperitoneal. So we need to know all these before starting a case. And we need to know about also the vascular involvement and also any role for preoperative embolization. So what is the preoperative embolization? As this is the case report that has been published, we can see the huge tumor in the proximity to the vessel that was chemoembolized. And in the first image, we can see that there is a huge blood flow to the tumor. After the embolization, the blood flow has suddenly dropped. So what is the use of this preoperative embolization? It reduces the tumor size, it makes the tumor more resectable, and it reduces the blood loss substantially. So when there are multiple collaterals or a single feeder vessel cannot be identified, that makes it less amenable, those tumor less amenable for embolization. And once the embolization has been done, it is mandatory to do the surgery within 48 hours. And during this period of post embolization, because of excessive tumor necrosis, patient has a substantially high pain, which has to be managed with adequate analgesia in the post-procedural period. Coming on to the intraoperative management of huge retroperitoneal sarcomas, it starts with the routine standard monitoring and widebore peripheral lines, invasive blood pressure and central lines. Cardiac output monitoring can be used in high-risk cases, especially to guide the fluid therapy. In patients with poor venous access, we can even use the vascular cath or HD caths, which will help us to rapidly transfuse fluid. And the same vascular caths can be used in the postoperative hemodialysis also if needed, as these patients undergo nephrectomy in the during the surgery. And we should go for blood requirements, the maximum blood order schedule according to the according to the hospital protocol should be communicated to the blood bank, and cross matching should be done prior. We have to maintain the normothermia, fluid and surface warming should be done. Vasopressor infusions can be kept ready. ABG and point of care coagulation monitor should be kept in the OT complex. The TE has a role only when there is an intravascular thrombus or a DVT. As such, these tumor usually engulfs the major vessels. It is not that they have an intravascular extension, so they do not present much with a thrombus as such. They usually engulf the tumors, engulf the major vessels. So as such, the intraluminal thrombus in these cases are very rare. So coming on to the anesthetic management, we can either go for the inhalational or TIVA, TCI-based, propofol, remifentanil-based anesthesia. So our general anesthesia should be guided by either BIS or the entropy to know the depth of anesthesia, because we usually titrate our anesthetic depth intraoperatively when there is a huge hemodynamic instability that increases the risk of awareness. So we need to guide the management by BIS or entropy. Whenever there is a huge mass in the upper quadrant, it may necessitate the use of rapid sequence induction or even awake intubation if the gastric emptying is delayed. Epidural analgesia becomes the gold standard, but whenever there is a vascular resection and reconstruction is planned, we may have to think of other options other than epidural analgesia. So the major task will be to maintain the normothermia throughout the procedure. The patient position will be supine in majority of the cases, because the intraperitoneal approach is usually done. They go from the midline, because that is where they can have a better control of the vessels. And if the patient has a preoperative chemo and associated diabetic, hypertensive, old age, we may have to be very meticulous in padding them and positioning them, because there can be a subclinical sensory nerve damage. So that may be aggravated in these patients because of their prolonged duration and hemodynamic instability. So adequate padding, soft base, arm abducted, kept in pronated, even the heels has to be adequately padded. For surgical access, mild hyperextension of the back is given. And as far as the intermittent pneumatic compression is advised, here it is usually avoided, because the pneumatic compression tend to increase the venous bleeding in these cases. Coming on to the perioperative fluid management, as the recent guidelines say, it is always the individualized fluid management. We have to take into the account of the surgery, the patient factor, the volume status, and what are the acute and chronic comorbidities in the patient. The general consensus, as for any ERAS protocol, it is to reduce the preoperative fasting and carbohydrate loading. We have to adequately have an individualized fluid administration, and not to exceed the 1 or 2 liter of positive balance at the end of surgery. This is because the recent BJ article says, when we have a zero balance in the at the end of surgery, we tend to have more complications of AKI and hyperperfusion. At the same time, excessive fluid administration causes more respiratory failure, tissue edema, ileus, and etc. So it has been found the cumulative balance, fluid balance of 1 to 2 liter at the end, not exceeding 1 to 2 liter, keeps the patient in this blue zone over 5 to 6 hours of surgery. Coming on to the tumor that involve the vessels, angiography gives us a picture about what is the vessel that is involved, what is the extent of the vessel involvement. Also tells the surgeons about whether there is a proximal tumor-free space where they can clamp. Whenever there is an IVC reconstruction at the time of en bloc resection, this has been found that it does not affect the mortality or morbidity. So any IVC involvement should be considered to be give a heads up to go for the en bloc resection. If the tumor location is retrohepatic, inflow control on should be done with combining the clamping in the infrahepatic vena cava and Pringle's maneuver. So whenever this is done, there will be a higher sudden bouts of hypotension that has to be managed with fluid boluses and vasopressors as and when necessary. We have to take care that the total ischemia time of this clamping doesn't exceed 30 minutes in total. Coming on to the IVC reconstruction. So whenever there is an IVC reconstruction, there can be just a primary closure or a graft or a patch that can be put in, or maybe sometimes ligated also. So any of these can happen when we have to reconstruct the IVC. So that has to be also discussed with the surgeon, what is their plan of IVC reconstruction. So during the clamping, we have to give systemic anticoagulation of heparin, and the field is flushed usually with heparinized saline. The plan of reconstruction is you will be primary closure if the lumen narrowing is less than 50%. Whereas if there is a circumferentially en bloc, the whole segment of the IVC has to be resected, it is reconstructed with the ringed PTFE. So what is ringed PTFE is, there are small rings to which the branches of IVC, like the renal vessels, can be reimplanted. So during the whole reconstruction, the IVC is kept clamped. But this, whenever there is an unclamping, we have to be actively involved. We should put the patient in the Trendelenburg position, give a Valsalva maneuver to flush the IVC, remaining IVC with the blood, fill it with blood, and the graft is also filled with heparinized saline. So this reduces the chances of venous air embolism. And with the PTFE graph, it has been found that there is no risk of increased venous thromboembolism. Whenever there is a chronic IVC occlusion and a smaller segment has to be resected, and there are excessive collaterals that are already found, then the reconstruction may not happen. So moving on to the patient blood management, which is a major crucial part in managing these kind of cases. So what is the patient blood management is the timely application of evidence-based concept in an effort to minimize the allogenic blood transfusion and to improve outcome through three pillars. So what are the three pillars? Those to optimize the RBC mass, reduce the blood loss and bleeding, optimization of physiological tolerance towards anemia. So, with preoperative optimization and anemia correction, we may have a better tolerance to anemia. But to reduce the intraoperative blood loss, we may have to have multiple protocols. Like, yeah, as the average blood loss in retroperitoneal sarcoma is around 7 liter, especially if the solid organs are involved. So this has to be kept in mind when we are managing these type of cases. As far as the tranexamic acid and antifibrinolytics are concerned, the we have to be cautious in two aspects when in these cases. One thing is if the patient has received bleomycin, the tranexamic acid tends to interact with bleomycin and increases the chances of venous thromboembolism. And also in patients whom we are going to heparinize and go for an vessel reconstruction, it is better to avoid in those kind of patients. So coming on to the main thing, the autologous blood donation, which may not be practically possible in these patients if they are post-chemo, and patients who are acute normovolemic hemodilution can be done in patients who present upfront and have a good hemoglobin in the preoperative period. In that cases, we can collect up to 3 units of blood with the wide bore cannulas that we usually put for these patients. And during that period, autologous collection, we can maintain the hemodynamics with crystalloids and colloid. The main advantage of acute normovolemic hemodilution is it is more cost effective and it improves the tissue oxygenation better because we are transfusing the whole bed and the risk eliminates the risk of dilution coagulopathy and also the thrombocytopenia. So coming on to the intraoperative self-salvage, I'm not going to deal with the excessive details of this procedure, but in short, the dual suction is used to suck from the abdominal cavity. It goes to the reservoir and through the centrifuge pump to the reinfusion bag via the filter, that is leukocyte depletion filters. It go through the cannula is transfused to the patient. So what is the advantage of this technique is it causes better oxygen delivery, good volume expansion, the post-op hemoglobin levels are better than a donor transfusion and is useful in Jehovah Witness and rare blood types. But the main disadvantage comes is the availability of such intraoperative cell salvage technique in our institute. The cost, staffing and training and getting familiarity with these uses the main rate limiting problem in the usage of intraoperative cell salvage. And the other disadvantages include the reinfusion hypotension that happens in these patients, especially if the LDF filter with the recent newer LDF filter, the reinfusion hypotension is more. There may be risk of embolization. And also we should keep in mind these intra cell salvage blood that we use, they predominantly give only the red blood cells. They still lack the platelets and clotting factors and calcium that has to be replenished by us. So the recent evidence of intraoperative cell salvage in oncology is there has been concern about tumor dissemination and plantation and distance metastasis with the use of IOS blood. That is a physiological assumption that has been there. So over the years, it has been found the newer generation leukocyte depleted filters, they filter up to 99 to 99.9% of the tumor cells. And the chances of recurrence and overall survival has not changed over by avoiding IOCS, especially in large variety of tumors in prostate, osteosarcomas, breast cancer, lung cancer, etc. So this is the recent evidence that has been published. So moving on to the massive transfusion protocol, as I said in the earlier slides, whenever we are doing such cases, the blood bank has to be alerted and about such a case happening and blood order should be already placed. And we should this will help us to serve a delegate task and streamline the workflow once it is activated. So once it is activated, it is mandatory that we get a predefined ratio of different blood products for transfusion within 15 minutes. So such protocols also helps us to guide the goals of to continue or to hold the transfusion. So what will be our goal for such transfusion will be either laboratory parameters or the viscoelastic testing. So laboratory parameter targets will be usually the hemoglobin of 7, plans for transfusion target of INR of less than 1.5, and cryoprecipitate target to fibrinogen level of more than 1.5 grams per liter. But drawback with the lab parameters is more time is used for getting these information, and it's a one point of one test, and there is no information of clot strength, platelet function, subsequent fibrinolysis is all not available with these lab parameters. So initial resuscitation, even though done with a fixed ratio of blood, which should be followed by goal directed transfusion, especially point of care viscoelastic testing. So the point of care viscoelastic testing involve the TEG and the ROTEM. The graphing and all the details, I'm not going to deal with it. But the TEG and ROTEM, the main 4 parameters that we usually see is the clot formation, clot kinetics, clot strength, and the clot lysis. Both the TEG and ROTEM have given different terminologies to define these things. The usual TEG uses the kaolin activator, but the recent advance is the RTEC, that is the rapid TEC, where the tissue factors are used to, instead of the kaolin reagent, to activate the blood coagulation. This activates the extrinsic pathway also. So this gives results within 15 minutes. It also gives the ACT values. It also gives has a lesser R time than the conventional TEC. The alpha angle is more acute compared to the conventional TEC. As we can see in this table, the R value for any normal TEC is around 9 to 27 minutes, but in R TEC it is only 0 to 1 minute. And alpha angles are 22 to 58 in a normal TEC, but rapid TEC is 66 to 82. So there are transfusion triggers that have been set for even R TEC parameters. So any massive transfusion is not devoid of complication. The major complication we face is the acidosis because of the hemodynamic instability, transfusion of stored blood, etc. This acidosis per se reduces the clotting factor activity and thrombin generation, also causes degradation of the fibrogen. So we need to maintain a goal of pH of 7.2. If it is less, we can consider giving a soda bicarb. Maintaining temperature is another task in hand. Any 1 degree drop in the temperature can cause a drop in the clotting factor activity by 10%. And if the temperature drops below 33 degrees, the clotting factor activity goes by 50%. This whole hypothermia-induced clotting dysfunction is reversible. So we need to have a preventive mechanism to have prevent this clotting factor activity reduction. And the ionized calcium levels also goes down with the massive transfusions, and this can lead on to coagulopathy and impaired cardiovascular function. The potassium levels also vary. It with multiple transfusion, it tends to cause more hyperkalemia, but in some cases there can be a dilutional hypokalemia also. So repeated lab values or the repeated ABG with the electrolyte should be monitored to give correction appropriately. Coming on to the ERAS protocol, the ERAS protocol for as such retroperitoneal tumors have not been defined because of the rarity of these tumors. But in RP-LND cases, they have been found that the ERAS protocols with no bowel preparation, avoiding nasogastric tube, early mobilization and oral nutrition, even chewing gums, standard nausea vomiting management has reduced the VAS course over 7 days, has reduced the shorter hospital stay, and also reduce the morphine equivalent doses. So, and they have also found they have reduced this ERAS protocol has reduced the incidence of ileus in the postoperative period, wound dehiscence, fewer readmission, and lesser length of stay. So as far as possible, as per the institutional protocol, the ERA, whatever components of the ERAS can be done in these patients should be definitely followed. Coming on to the analgesia, the main aim will be to give a multimodal analgesia. Epidural local anesthetic or the epidural infusions are preferred, but the another concern that has to be done with an epidural local anesthetic should be any vascular clamping or the major vessel clamping, especially the aortic clamping or the branches clamping that was done during intraoperative period, there can be, especially in the left-sided dissection, there can be an associated anterior spinal artery syndrome, which will cause paraparesis of the lower limbs, which will be masked if we use an epidural anesthesia. So there has been case reports where retroperitoneal sarcoma dissection patients post-operatively had lower limb weaknesses that was masked because they attributed it to the local anesthetic infusion for 24 hours. It was stopped and then later it didn't improve. Then the clinical examination. So the local anesthetic delayed the identification of acute spinal artery syndrome in that patient. So that has to be kept in mind when we are administering local anesthetic. We need to discuss with the surgeon whether there was a handling or involvement of iota in any way. And epidural opioids are definitely useful and preferred also. Even intrathecal opioids, a single shot preoperative intrathecal opioid has also been very useful in reducing the postoperative analgesic requirements and maintaining an intraoperative hemodynamics. The other modality is the anterior abdominal wall blocks, the rectus sheath tap, which can be done either under vision or ultrasound guided. Wherever possible, we need to have a continuous abdominal wall catheters because single shot administration have no very good benefits, and we should try to have an abdominal wall catheter that can give an equivalent analgesics as per equal to a continuous epidural infusion. Especially it is reducing the pain at rest. Of course, for the pain on movement, the abdominal wall blocks may not be very effective, but they can definitely reduce the pain on rest. Coming on to the venous thromboembolism in the retroperitoneal tumors, the incidence is around 6.2, which is the highest among all the tumors, compared to the ovarian, which is only 5.8, or bladder 3.8% over 90 days of surgery. And the peak of venous thromboembolism is around the first and second week of post-surgery. So the risk factor for such venous thromboembolism will include the older age, tumors, recurrent tumors, higher organ resections, vascular resections, higher volume of blood transfusion, longer duration of surgery puts the patient at increased risk of venous thromboembolism. So the location of DVT is predominantly the lower extremity. So to avoid this, if the vascular cross clamping is done, better to have an intraoperative heparinization followed by the post-operative low molecular weight heparin and fondaparinol as early as possible. And it should be continued to up to the perioperative period, post-operative period up to 28 days. Post-operative complications include extubation will be depending on the intraoperative hemodynamic and the blood loss. Patients are usually shifted to a HDU or ICU care. The most common complications involve the ileus, the chylous ascites, and the lymphocele. The intraoperative predictors of the post-op morbidity involve the blood loss of more than 1 liter, two or more organ resected, longer operative time, lower serum albumin, and leukocytosis. All these are predictors of post-op morbidity in these retroperitoneal tumors. Coming on to a small indication and outcome in a retroperitoneal lymph node dissection, these are commonly done for the testicular tumor, especially the non-germinomatous germ cell tumors, rarely for renal cell or ovarian or upper urinary tract urotheliomas. These tumors are usually very chemosensitive. These patients, after a BUP chemo, if they have a persistent lymph node involvement, they undergo retroperitoneal lymph node dissection. The main survival of after an RP-LND for such tumor is around 89% of 10 years survival. So these patients have a very good outcome if they have successfully removed the persistent lymph nodes. So what will be the surgical approach for such patient will be the bilateral infrahilar template is excised. It is around the iliac vessels, aorta, and the IVC. Sometimes there may be an extensive or a huge node that may be extending to the above the infrahilar, or sometimes it may be extending up to the thorax as well, which may need an thoracotomy or VAD surgery. But predominantly the RPLNDs involve these bilateral infrahilar templates. What is the important main technique that is followed by surgeons is to preserve the paravertebral sympathetic ganglion here. The sympathetic fibers that pass through these along these major vessels, which lies in between the lymph nodes, has to be preserved as much as possible. To and that technique is called nerve sparing technique. Why is it very important? Is these sympathetic plexus are very important for maintaining the ejaculatory function of the patient. As these patients are relatively younger patients and they have a very good survival, we need the surgery has to avoid the retrograde ejaculation. So, surgical team tries to have a nerve sparing technique whenever possible. But this prolonged dissection can happen. There increases the duration of surgery because meticulously they have to separate the sympathetic plexus as well. There can be 5% chances of high blood loss because of the proximity to the vessel, and associated nephrectomy may also happen in around 11% of these cases. So anesthetic management, as we discussed earlier, will have will be in similar lines, and these patients are usually come with after a BEP chemotherapy. So it is better to titrate their oxygen supplementation to maintain a SATs around 89 to 94%. Only in cases of high blood loss or in emergency, the oxygen concentration can be increased to improve the tissue oxygenation. Coming on to the robot-assisted retroperitoneal lymph node dissection, it is usually done in a supine position. Very rarely, when there is only a unilateral dissection is planned, there can be a lateral position. As we all know, robotic surgery has better visualization, reduced blood loss, length of stay, and have a similar oncological outcome. But the main concerns for us will be the positioning, the limited access to the patient, and prolonged surgical duration. And we need to maintain the intraop FiO2 around 0.21 to 0.3. We can even do serial ABG to know about the hypoxia in these patients. So the main concern of robotic surgery in these patients will be these, as I said, there'll be dissection that will be happening around the blood vessels, meticulous dissection, but there can be an emergency catastrophe that can happen, leading on to a vascular injury. So this is in RPLND, the increased chances of emergency undocking can be there. So we need to have a protocol in place to have a regular undocking, emergency undocking system. So usual undocking takes about 3 minutes, but with skill training and proper protocols, we can reduce this time to around 1 minute. And we have to the surgeon has to clearly communicate whether they want an open post vascular injury, they want to do an open laparotomy, or a laparoscopic can be managed. And in the meantime, we have to have a fluid resuscitation ongoing in the during the emergency period. So this is a guideline that robotic undocking for emergency support protocol that has been given by the Da Vinci system as well, where the robot conversion during a massive hemorrhage protocol has been given, where they have defined roles for everybody. The surgeon sitting in the console, the surgeon sitting in the bedside, the anesthesiologist, scrub nurse, everybody has been given a proper role, which has to be done with a teamwork, good clear communication, role assignment, and skill training. So how do we do skill training is by the high fidelity training simulations. By having a good simulation, we can go for a better outcome in these patient. So how do we initiate this will be a trigger word. Everybody in the OR should know the trigger word, and it is the anesthesiologist or the surgeon sitting in the console who has to utter these trigger word like emergency undock. So we need to have a periodic training of all the OR staff on the surgeon and anesthesiologist to have a better outcome during an emergency undocking. Moving on to the postoperative complication in the retroperitoneal lymph node dissection, the incidence is very high in post-chemotherapy patients who have undergone open surgery, have a high BMI, and it has been found that the left-sided dissection, where there is a more mobilization of the small bowel, etc., have more incidence of postoperative complication. And the first complication that is commonly seen is the chylosositis, and which can be managed conservatively or sometimes need an exploratory laparotomy as well. And ileus is the second most common complication, followed by ARDS, pneumonia, and atelectasis. So it's the time to wake up. Thank you everyone for the patient listening. And any questions, please feel free to share.
Thank you, Aishwarya. That was a very detailed, conceptualized lecture. So we do have one question. So what is your, would you consider using tranexamic acid in patients not using bleomycin or where grafts are not mandated?
Yes, tranexamic acid definitely has a role in these patients. Even the recent guidelines has prescribed to use a tranexamic acid in these patients, in patients with anticipated excessive hemorrhage. So we can, yes, we can use tranexamic acid if there is no particular contraindication as discussed here in these patients.
Yeah, I think in one of those guidelines that you referred to, the 2024 guideline.
Yeah, anesthesia, yes.
ATBM. Yeah.
Mhm.
It says actually that it should be part of your surgical checklist.
Yes.
They've recommended that we think about tranexamic acid in nearly all the cases where we think these patients are going to bleed a lot, and we can sort of stop the clot dehiscence. Nivedya has a comment. I have seen in one patient prolonged neutropenia as a postoperative complication in a patient who had RP-LND with massive blood transfusion, splenectomy, and nephrectomy.
That's a new point to learn, actually.
Yeah, it's a learning point. So maybe there are other aspects to that. This massive blood transfusion throws up some immunological challenge where a splenectomy has already been done, maybe something like that. I'm not.
Yes.
If anybody else can add on to this point, please feel free. We also have one more comment. Individual renal function, why is this mandated? If the tumor necessitates removal of one kidney, we have to allow it to for the full resection of the tumor. So why subject the patient to an additional test and increase the cost of treatment? Do you have any thoughts on this?
It is like to know the whether we can allow to know the preoperatively we can counsel the patient. If the split function is bad, we may have to have the patient, even if he undergoes an nephrectomy, him if the other kidney is not functioning well, we have to counsel the patient first that he may go in for a postoperative hemodialysis, or even he become hemodialysis dependent also. So that counseling mandates this test to know that whether we need that counseling and consent from the patient. So that is one important aspect. Second aspect will be to know whether we can have a nephrectomy on board. If both the kidneys are already CKD or their function is very bad, the surgical operability itself will may vary, because as I said, these patients have a very poor survival in spite of extensive resection. So the risk benefit has to be analyzed. So for that, we may have to subject them to this surgery, this test, I think.
Yeah, that is, there can be one more aspect to it. Whether if the other kidney function is very, very poor, then you could go in for a nephron sparing resection on this side.
Yes, yeah.
Better chance of having some renal function later.
Function later. There's another question.
Yeah.
Any comment on the hemodynamic management of these patients in the post-op period? Frequently, it is observed that these patients. Sorry.
Yeah.
I'm not able to see that.
Persistent low diastolic pressure, prolonging the ICU stay. What do you think would be the probable causes and management options?
One thing that we have usually seen with these patients is that the lymph node dissection per se causes a lot of fluid shifts. And there is a lot of lymphatic edema, and as I said, the chylous ascites are very high in these patients. So they may be losing a lot of protein there. That may reduce their intravascular volume, even though in spite of the indicator showing that they have a good vascular volume and all those, the lower protein loss that happens during these patients may be one of the main reason that causes the persistent low diastolic BP, or that has to be managed. Discuss with the surgeon about whether they're suspecting any chylous injury, or even the albumin infusion or colloid infusions may be done. That could be the management option that I can think of.
Yeah, Dr. Virinchi, I think mostly it is the fact that the oncologic, the osmotic pressure and oncotic pressure are inadequate. So when the patient is losing blood, he's losing whole blood, all the components of blood. Whereas because we have all these components, we are replacing them, uh, those components which we test for. So we may not replace adequately, and that needs to be looked at.
Yeah, so Sohn here, can I comment?
Sure.
Yes, sir.
Yeah, so actually that Ashwarya rightly mentioned that most of the time in these patients, because of the a lot of fluid loss because of the lymph node dissection and all these things, and the protein loss and the oncotic pressures are low. So these patients, they remain hypotensive in the post-op period. So like you all mentioned rightly that correcting the volume status, especially the protein part with the albumin or with the
TPN.
TPN or with the early
TPN.
start of feeding and all these things that can help in preventing the of this prolonged hypertension and the other complications in this patient. So post-op management is also important part when you go out this type of surgery.
Yes, sir.
Yeah, I think there's
And
a
because of the sympathetic handling that happens, because as I said, nerve sparing they do try to shave the tumor from the sympathetic beds as well. So that is also one of the main reason for the persistent tachycardia. Actually, the other question is on that. So that is also an important aspect that happens in these patients because post-operatively they do remain, as I said, volume depleted. That can be indicated by that persistent tachycardia, delayed bowel resumption, and there'll be a mild picture of ARDS or mild even picture of uh, impending sepsis. So these are very commonly seen in the postoperative period in these patients.
I think the post-op recovery is pretty prolonged in these patients. And with that will dictate your 30-day, 90-day mortality as to how you handle the post-operative period. So that is a very crucial part, and quite a few questions are based on
And
that.
and actually, many a time these patients they go into surge intraoperatively, and that surge remains continued in the post-op period. So that's one of the cause of the tachycardia is also because the patient is having this surge and all these things. So we will have to manage according to that. Yeah.
Dr. Namrata says we have often noticed non-infective
Yeah.
fever patients. Yeah, that's very true.
That was said.
Yeah.
That is the SIRS, as I said, like there is a lot of inflammatory cytokines because the lymph node dissection and the sympathetic dissection that happens. So that is the main reason for the non-infective fever. You will usually, as I said, there'll be tachycardia, there'll be fevers of spikes, there'll be mild impairment of oxygen ratios, but all the cultures will be negative. So such a picture is usually seen within post LND dissection. One of the main reason is the lymph node dissection that is happening. The huge lymph bed is dissected. There's a lot of fluid loss, and also the sympathetic fluxes are handled. So these are the main reason the patient's presence in such a way in the post-operative period.
We seem to have done with the questions now, unless anybody's putting in any. Sohan, would you like to add anything at all?
No, so no, not in this case, but I want to add something else after you finish this case.
Aishwarya, would you like to say anything at all?
I think most of them have covered in the slides, and a very useful discussion that has happened about the post-operative period also.
So thank you. Thank you to all the audience for participating and bringing up different points that we could discuss. And Aishwarya did a very thorough job. So thank you, Aishwarya. I'll
Thank
hand
you,
over
ma'am.
to Sohan for what he would like to say.
Yeah, so I just want all our exam going fellows to remain in login. So actually, our next webinar we want to do orientation type of things of our forthcoming exam in the March. So and then after 15 days we will not have a formal lecture, but we will have that day. We will be all the examiners and all these moderators will be they'll give you a brief orientation on how the exam will be conducted of SOPSI and what all will be done when you go for exam for exit exam of FOPM. So I just want to say that is only. So the next webinar will not be a webinar. We'll do a orientation of an exam.
So that's 6th of February, right?
Yeah, 6th February.
Yeah. Okay. Great. Nice.
Mm.
So then on this note, I shall conclude today's session. Thank you all the participants for joining us. And thank you, Aishwarya and Dr. Sohan.
Thank you, ma'am.
Hand over to Rupsa to conclude the session. Right, Rupsa does not seem to be around, so please feel free to leave. Good night.
Thank you, ma'am. Bye.
Thank you so much, everyone, for giving us the opportunity to host the session. Thank you.